Number 1. A bullet older than me. This case involves a World War II veteran who had been living with chronic sinus infections, headaches, and an odd feeling of pressure behind his nose for decades. Nothing he tried ever solved the issue. Not antibiotics, not decongestants, not allergy treatments. Eventually, after nearly 30 years of symptoms, a new doctor ordered a sinus x-ray to understand why the infections kept coming back. The scan immediately showed something that shouldn't have been there. A small metallic object lodged behind the nasal cavity, sitting just above the palate. It was shaped like a pistol round. The man had been shot in the face during the war and treated in a field hospital. Back then, surgeries were quick. Life-saving procedures meant stopping bleeding and infection, not meticulous reconstructions. The bullet had apparently entered at an angle, ricocheted inside the nasal passages, and lodged deep enough that it wasn't discovered until the initial treatment. Over the years, tissue had grown around it. It didn't move, but it irritated the surrounding sinuses every time he breathed, sneezed, or changed altitude. Doctors decided to remove it using endoscopic sinus surgery, a camera and tool inserted up through the nose rather than through an external incision. The procedure wasn't simple. Decades of scarring had anchored the bullet in place. When surgeons finally extracted it, the round was still intact, with scratches from its path and corrosion from years inside a moist cavity. Once removed, his recurring infection stopped entirely. It was one of the longest known cases of a foreign metallic object remaining inside the sinuses without being discovered. Number 2. A spoon. This case involved a woman who accidentally swallowed a metal spoon while trying to trigger her gag reflex. She was attempting to remove something stuck in her throat, slipped, and the spoon went straight down. She felt discomfort afterward, but didn't go to the hospital. The initial pain faded, and she assumed it would pass through on its own. It didn't. For almost a full year, the spoon stayed in her stomach. The organ is spacious and muscular, so it managed to hold the object without immediately causing a blockage. But a metal utensil isn't smooth or flexible. With every stomach contraction, it scraped the lining. Over time, the spoon's edge began resting against the same area repeatedly, creating pressure sores. Months later, she developed persistent upper abdominal. By the time she finally sought help, the discomfort had grown into sharp stabbing pain whenever she bent or twisted. Doctors performed an x-ray and immediately saw the full outline of the spoon. Unmistakable, solid metal, about 10 centimeters long. An endoscopy was attempted first, but the spoon had rotated into a position that made pulling it up through the esophagus too risky. The edges could tear soft tissue on the way up. Instead, surgeons pulled a small incision and opened the stomach directly to remove it safely. The utensil had already begun to cause small areas of erosion along the stomach wall, but it hadn't yet created a full perforation. Once removed, her symptoms disappeared. The tissue damage healed, and she recovered without complications. Number 3. Growing a pea plant. A man in Massachusetts developed persistent coughing and shortness of breath that didn't match any obvious infection. At first, doctors suspected pneumonia, but antibiotics didn't help. Over several weeks, the coughing fits became sharper, and he started feeling a constant pressure in his chest. A CT scan finally showed a small mass inside one of his lung passages, partly blocking airflow. When surgeons went in with a bronchoscope, a small camera inserted through the airway, they saw something unexpected. Instead of a tumor or hardened mucus plug, they found a small green sprout. A pea plant had started to grow inside the lung. Months earlier, he had accidentally inhaled a pea, and instead of dislodging or breaking down, it had become stuck into the bronchial tube. Lung tissue is warm, humid, and exposed to carbon dioxide, all of which can support germination. The pea had absorbed enough moisture to split and send out a tiny shoot. The plant wasn't large, but it was long enough to collapse part of the airway and irritate the surrounding tissue. The irritation was responsible for the severe coughing that brought him back to the hospital. Doctors removed the sprout carefully using endoscopic tools. Once it was out, it was clear it had real roots and a pale green stem, around a centimeter long. After removal, his breathing improved almost immediately. Foreign object inhalation isn't rare, but plant germination inside the lungs is extremely uncommon. Number 4. Surgical scissors. After a C-section in Australia, a woman began experiencing persistent abdominal discomfort that never fully went away. At first, she assumed it was normal post-surgery soreness, but the pain gradually shifted from a dull ache to sharp stabbing sensations. Over time, the discomfort started radiating toward her ribs and lower back. She returned to doctors several times, and the explanations ranged from muscular strain to scar tissue complications. It wasn't until 18 months later, when the pain became severe enough to interfere with walking, that a more detailed scan was ordered. The X-ray image was immediately clear. A pair of 8-inch surgical forceps had been left inside her abdomen during a C-section. The tool had slipped deep into the abdominal cavity and remained unnoticed during the routine instrument count. Over the following year and a half, it had shifted positions multiple times. Each movement allowed one end of the forceps to scrape or press against tissue, causing the sharp pain she had been reporting. Surgeons performed a corrective operation to remove the instrument. They found it lodged near the right side of the abdomen. Fortunately, it hadn't punctured any major organs, but had caused significant irritation and inflammation. Once the forceps were removed, her symptoms resolved, and she recovered normally. Cases like these are rare, but they still occur when instrument counts fail or surgeries are rushed. Number 5. A 5-foot tapeworm. A man in China went to the hospital after years of abdominal discomfort, unexplained weight loss, and episodes of nausea that came and went without any clear pattern. He had been living with these symptoms for so long that he considered them normal. Routine tests didn't reveal much until doctors examined a stool sample and found tapeworm segments, pieces of a parasite that break off and exit the body. Further imaging showed something long and ribbon-like inside his intestines. It was a Taniasolium tapeworm, a species that can grow to several meters in length. In his case, the worm was about 5 feet long, folded multiple times inside the small intestine. Tapeworms attach themselves to the intestinal wall, using tiny hooks on their head, and absorb nutrients directly from the food passing by, which explained his weight loss. Doctors administered an anti-parasitic medication designed to detach and kill the worm. After the drug took effect, the parasite loosened its grip on the intestinal wall. The removal process was unpleasant but necessary. The medical team slowly extracted the worm, which came out as a long, flat, pale ribbon. Much of it was still intact, which indicated it had been alive and feeding for a long time. Tapeworm infections usually come from eating undercooked pork contaminated with larvae. In many cases, the parasite stays small or goes unnoticed. But when it grows to this length, it can cause persistent discomfort, nutritional deficiencies, and intestinal blockages. Once the tapeworm was removed, his symptoms resolved quickly, and he gained back the weight he had lost. Number 6. A live fish. This incident happened in India and started as a reckless bet among friends. A man inserted a small fish, similar in size to a juvenile catfish, into his urethra. What he didn't expect was how quickly it would move. Once inside, the fish used its fins to propel itself upward. It traveled through the urethral canal, past the prostate area, and eventually entered the bladder, where it became trapped. He felt an immediate burning sensation followed by sharp internal pain. Within minutes, he was unable to urinate. The fish was swimming in a confined space, scraping the bladder lining each time it moved. As the bladder tried to contract, the pressure increased, causing severe discomfort. After several hours of worsening pain, he went to the hospital. Doctors performed an ultrasound and saw movement inside the bladder. The fish was still alive. The only safe option was cystoscopy, where a thin instrument with a camera is inserted through the urethra. When the scope reached the bladder, the fish was clearly visible swimming in circles, causing continuous irritation to the surrounding tissue. Using small extraction tools, the surgeons had to catch the fish without tearing the bladder wall. It took multiple attempts because the fish kept slipping away. Eventually, they secured it and removed it through the same pathway it entered. The bladder lining showed inflammation and small abrasions, but no full tears. After removal, the man recovered without long-term damage. Urinary tract foreign bodies are rare, but this case stood out because the object was alive and capable of moving deeper into the body on its own. Number 7. A 3-foot eel. This case, reported in China, began when a man arrived at the hospital with severe abdominal pain, intense bloating, and difficulty passing stool or gas. He claimed the eel had entered his body while he was bathing, though the medical team strongly doubted that explanation. Regardless of how it entered, the animal had made its way into the rectum and continued moving upward. Eels are strong, flexible, and capable of burrowing through tight spaces. Once inside the lower intestine, this one tried to push forward instinctively. As it moved, it scraped the intestinal lining and caused internal tears. The man began experiencing fever and tenderness across his abdomen, signs that the eel might have penetrated deeper and caused infection or leakage of intestinal bacteria into surrounding tissues. A CT scan showed a long, dense object extending through the rectum and into the sigmoid colon. Because eels are slippery and difficult to grasp, doctors could not remove it manually. They had to perform surgery to access the intestine safely. During the operation, they found this eel alive, nearly 3 feet long and lodged deep enough that it had to be pulled out section by section to avoid rupturing the intestinal wall. Parts of the intestines were inflamed and showed signs of early infection where the animal had pressed or scraped against the tissue. The eel was removed intact, and surgeons cleaned the damaged areas to prevent sepsis. The patient required antibiotics and monitoring afterward, but he survived without major long-term complications. Foreign animals in the digestive tract are uncommon, but when the object is alive, mobile, and capable of digging forward, the risk of internal injury increases dramatically. Number 8. A grenade. During military operations in Iraq, a soldier survived an explosion from a fragmentation grenade but continued experiencing sharp chest pain and irregular breathing afterward. He assumed it was bruising or muscle injury from the blast. It wasn't until a field X-ray and later detailed scans that doctors realized the actual cause. A piece of shrapnel had entered his chest, passed between his ribs, and lodged in the wall of his heart. The fragments were small, only a few millimeters, but it was embedded in the myocardium, the thick muscular layer responsible for pumping blood. With each heartbeat, the metal shifted slightly. It hadn't pierced all the way through the chamber, but it was deep enough that any further movement could cause internal bleeding or a fatal rupture. The risk wasn't only medical. Some grenade fragments retain explosive residue and can remain reactively unstable. Because of this possibility, a bomb disposal specialist had to be present during surgery. The operating room was partially cleared, and the surgical team wore protective gear. Doctors opened the chest cavity and used imaging to locate the exact position of the shrapnel. The heart was still beating. Stopping it would have increased the risk of dislodging the fragment. Using small clamps and guiding instruments, surgeons extracted the metal without letting it cut further into the tissue. Once removed, the heart was inspected for leaks or tearing. Fortunately, the fragment had lodged in a stable area, and the soldier recovered after several weeks of monitoring. Cases like this are rare because most people hit by shrapnel in the heart don't survive long enough to reach surgery.